Next, we're going to take action, or actually do the thing. They want to know, what will you do? Should you do it? How should you do it? And in this case, you're an experienced nurse now, so you've been a nurse for a little while, and you're supervising a new graduate nurse who's preparing an IV insulin infusion. So high risk med. I already told you guys that that's not an option here. So we already told you that we have to give it on a pump. That's one of the things we do to keep them safe. But which action by the new grad nurse would cause us to intervene? So we are looking for something they're doing that is unsafe, that makes us want to stop them and correct them. All right, so do we want them to verify the concentration of regular insulin in the IV bag? Yes, and in fact, we need to do that together. Most facilities that you guys will work at as a nurse, when you're giving a high-risk medication, it requires like a 2-nurse sign-off. So 2 people actually look at it and go through your 10 medication rights together. So that's correct. I'm going to cross this one out because I don't need to intervene for that. Then, am I going to verify that 50% dextrose is available to reverse hypoglycemia? Yes, if I accidentally give them too much insulin and drop their blood sugar, now their cells in their brain aren't getting enough glucose. So you need to treat that with that 50% dextrose, which if you guys have ever given it, it's like syrup in a syringe and it's really thick to push. So yep, 50% dextrose, have it just in case. Then waiting for a second nurse to verify the dose before starting the infusion. Yes, that's a very important safety step, to have that second line of defense looking behind you. Then finally, request an order to add dextrose to the IV fluids once glucose is under 100. So we do, remember, worry about creating hypoglycemia, giving too much insulin, and it might seem counterproductive to add dextrose or add more sugar to somebody who already has a super high blood sugar, but hypoglycemia is more dangerous than hyperglycemia. And Oman is right. He said that's it's answer 4 because 100 is low. Rick says yes, right. We want to be a lot more cautious than this. We want to make sure that before it gets below 100, we're adding some dextrose to the fluid so that we aren't dropping their blood sugar too fast. And we're only checking their blood sugar every hour, right? So we're not going to know that there's a problem until maybe an hour later. So this would cause me to intervene. I would say, no, we need to do this once the glucose falls under 250. So as soon as their sugar gets under 250, we change their IV fluids and could just continue to slowly taper. Well done, you guys. All right, then I'm evaluating the outcomes, figuring out, did it help or was it effective, or what signs would indicate a complication. All right, so now we've got this update. We're gonna read it again here. So this is after, looks like overnight. So they were admitted around 5 p.m. Now it's around 3 a.m. and we've got some new complaints, and we're asked, click to highlight the findings in the nurse's notes that would indicate the client is not progressing as expected. So we are looking for unexpected findings that aren't in line with a normal recovery course. Complains of leg cramps and weakness. Based on the things 2 questions ago that we talked about complications we're worried about, because we're worried when we're treating DKA that we're going to see hypoglycemia, cerebral edema, maybe hypokalemia, possibly even fluid overload if we give fluid too fast. So leg cramps and weakness, does that fit with one of those complications that we've been monitoring for? Let's go on to the next one. We've got vomited 50 mils of clear fluid. Potassium level is 2.5. Yes. Hypokalemia. Beansy says hypokalemia. Aishia, you guys know it. Right. So we have accidentally given our patient hypokalemia through the treatment. It happens. That's okay because you're an experienced nurse, remember, and you recognize it. So potassium regulates your muscle contractions. So that's going to show up as leg cramps. You might have abdominal distension, hypoactive bowel sounds, and your heart is a muscle too. So you're going to see irregularities in the heart rhythm or the strength of the contraction. And so this creates big problems. But yes, leg cramps and weakness, that tells me hypokalemia, vomiting along with this abdominal distension, hypoactive bowel sounds. Our glucose is 225. And when they came in, it was 411, then 325, now 225. I think that's normal. I honestly can't remember, you guys, if this was a correct or an incorrect option, but From the look of this, we've gone down from 411 to 325. There's nothing I need to do about this. That's expected. At this point, I would just switch their IV fluids, but this is an expected thing. I expect to see their glucose going down, not too low. I expected to see their potassium going down, but not this low. So I'm going to leave this unselected. Then my cardiac monitor shows ST depression, flattened T waves, prominent U waves, and occasional PVCs. So that heart is getting irritable from that low potassium level. Then our heart rate's irregular. Yep, that's those PVCs. So we've got heart rate irregularities. Our pulse is 95, which is improved, right? From 101, 92, 95. So pulse is improving. Pulse ox is normal. Going to leave that unselected. Then my extremities are cool and my peripheral pulses are weak, which is not normal, right? We want warm extremities, strong pulses. And we're correct. So these findings all indicate hypokalemia. And in case you guys don't remember hyperkalemia, remember the T, when your potassium peaks, the T wave peaks too. So we see that really tall T wave is classic for hyperkalemia, and it's sort of the opposite for hypokalemia. So it dips in and stretches out and is prolonged. So we've got signs of hypokalemia, and what would you guys do to treat it? Yeah, we would need to give potassium, right? We actually need to replace the potassium and continue to monitor that.